Well, good afternoon. Welcome, everybody. I'm Shannon Brownlee. I'm Senior Vice President of the Lown Institute. The Lown Institute is a nonpartisan think tank headquartered in Boston, and we focus on health equity, high-value care, and accountability of the healthcare system. We believe a radically better system is possible, and we advance bold ideas to achieve this goal.
Hi, everybody. I'm Vikas Saini. I'm president of the Lown Institute. We just launched the Lown Institute Hospitals Index this past July. It is the first hospital ranking system that includes metrics of civic leadership and value of care. This is the first Lown Presents, so welcome to that. And to make sure you find out about future events, you should check lowninstitute.org/subscribe, and you'll be on our list. Today's session is going to be about racism and the hospital sector.
With us today, we have Milton Nuñez, who's the CEO of the New York City Health and Hospitals Lincoln Hospital in the South Bronx, and Dr. Mary Bassett, professor of public health at Harvard and the former health commissioner of New York City. A word of housekeeping. Please keep yourself on mute and you can turn your video off, but we encourage you to post questions in the chat anytime during this event.
Great. So for me, the kind of most insightful experience about race in America was when I was driving taxi in New York City. I had just arrived from Canada. And those of you old enough to know would know that in that period in the 70s, in South Africa, there was a regime of apartheid in which there were laws that kept the races apart. And the thing that really struck me as I worked the streets, especially in the night and evening shift, the most amazing insight was that America was apartheid and had no laws to enforce it in New York City. The market did a wonderful job. And I was truly amazed at how it worked, and it worked dramatically. You know, from one section, one neighborhood to another, I mean, it was almost like there were invisible barriers and gates. And of course, there were. So now, I think many people know and understand that there are similar things in American healthcare. And there's a truism in public health that your life expectancy is more determined by your zip code than your genetic code. And I think my experience as a cabbie sort of illustrated how that could work. And it certainly worked in the context of public health measures like life expectancy. We do have a slide that shows that. And for New York, it is just a subway ride away, between 10 years difference in life expectancy. Those of you in public health know you can do this for pretty much any city in the country. And often those discrepancies are even wider. So race is kind of woven into the deepest part of the fabric of American life, and particularly in healthcare. It's everywhere. And I think anybody who's thought about it or looked a little bit understands that. And that's true whether you're looking at high-level population metrics like life expectancy, or measures of chronic illness like diabetes, hypertension. It's also true when you look at insurance coverage, right? It turns out that you're more likely to be uninsured if you're Black, you're more likely to be uninsured if you're Hispanic than if you're white. Even when you have coverage, we know that access is also much less. That's true for access to primary care. There's one study I saw in which in certain neighborhoods in an American city that were African American predominantly had 28 times more likelihood of having poor access to primary care. That's a huge discrepancy. Same is true for specialty care. But even when you have access, we know that there are real disparities in actually the quality of care. And there are many metrics of that. And so, quality is a very complex measure. It's a simple term, but very complex measure. But we know that there are drivers of it that include perhaps resources and facilities, but also attitudes and communication. We know, for example, that implicit bias can influence or certainly is associated with varying rates of treatment, whether it's for thrombolytic therapy, clot dissolving therapy for heart attacks, or even the prescription of pain medications. It may be that the lack of minority clinicians, physicians, and clinical practice nurses might play a role, because it's also pretty clear that lack of communication, lack of trust matters. It's actually been shown that when providers are of the same race or ethnicity, you have a different quality of medication adherence, decision making, and all of those things almost certainly matter. So none of this is really news. There's a lot of research in recent decades. The real issue, I think, as all of us would probably now agree, is where's the action? And it's action and policy that is probably the most urgent thing that we have to tackle. The effects cascade throughout the entire system. And hospitals are one area where the kind of ubiquitous racialization of life in America really shows up. We know that minority communities tend to use hospitals for their general care more than doctors' offices or kind of a more traditional Marcus Welby sort of vision of practice. When we began working on the Lown Hospitals Index, we recognized that hospitals are the largest player in the healthcare system, certainly by dollars spent. And so we wanted to create a measurement tool, something that would help people understand what's going on, and also to promote an expectation that hospitals really ought to be in the business of advancing equity. So we measured what we call civic leadership, community benefit investments, pay equity, which includes the ratio of what a CEO makes to what the non-professional staff make, and inclusivity. And our inclusivity measure includes class measures like education and income and race. That triad is what we've called inclusivity, and that's what we're going to talk about today.
So I spent the 1990s as a senior editor at US News and World Report, which, as most of you probably know, publishes the most famous hospital ranking, America's Best Hospitals. And even then, it was pretty clear to me and some of my colleagues that our magazine's ranking painted an incomplete picture of what we should be expecting from our hospitals. In particular, that ranking and others that have followed, for the most part, failed to show which hospitals are doing the most public good. And that's part of what inspired the Lown Institute to create a new ranking, the Lown Hospitals Index. But when we started analyzing the data 2 years ago, we had no idea just how relevant our health equity and inclusivity metric would be today. Systemic racism in healthcare has become extremely important and relevant in the context of COVID-19 disparities. It's become relevant in terms of police brutality and relevant in terms of outcomes of racism that have recently come boiling to the surface. So there are some examples that we can pull from the headlines. So the Cleveland Clinic, for example, has its own police force, it turns out, which disproportionately cites and charges Black people around and on the Cleveland Clinic campus. We know that COVID-19 has impacted people of color disproportionately. The latest information from the CDC finds that from May to August, 24% of those who died from COVID-19 were people of color, Latinx or Black. And within the entire US, the population is considerably lower. 18% of Americans are Latinx and 12.5% are Black. The proportion who are dying who are of people of color is much higher. And this is a picture of Elmhurst Hospital, which is a group of people who are lining up around the block to get COVID testing. 1,500 beds in the city are empty, And people are lining up at this particular hospital, which was hugely burdened by patients with COVID-19. In terms of maternal mortality in New York State, the Department of Health found that 3 times more Black women died from pregnancy-related complications than white women. And this disparity persisted, amazingly persisted, even when the comparison was made between Black women who graduated from college and white women who did not finish high school. And it was estimated in this report that more than 60% of those deaths were preventable if appropriate care had been given in a timely fashion. Black women are also more likely than white women to report mistreatment while giving birth. 27% of Black women reported mistreatment like loss of autonomy, being shouted at, scolded, threatened, being ignored, refused help, or receiving no response to requests for help. 19% of women report such treatment. And Serena Williams had a pre-existing condition, clots, that she tried to get the attention of her providers at the time and felt like they were really not listening to her when she said, I have this condition. Another way that we know there's racism in the way Blacks and Latinx patients are treated is in clinical care protocols. These are the instructions that, or the guidelines that physicians use in treating patients. And recently, physicians have been calling attention to the fact that there are negative impacts from some of the clinical protocols or the clinical algorithms regarding care of Black people. For example, the heart failure risk score, which was written by the American Heart Association for Black patients, says they have a lower risk of dying in the hospital compared to non-Blacks, and the reasons the AHA does not provide. And this may lead Black patients to miss out on getting certain kinds of treatment that could help them because they're considered less at risk. There are other situations where these clinical guidelines have racial bias written into them that we may touch on later in this program. But now I'd like to introduce Dr. Mary Bassett. Mary has dedicated her career to advancing health equity. She's currently director of the FXB Center for Health and Human Rights. And if you want to know what FXB stands for, go find it on the web. It's hard for me to pronounce. And she's also the FXB Professor of the Practice of Health and Human Rights at the Harvard T.H. Chan School of Public Health. Prior to joining Harvard, Mary served as New York City's Commissioner of Health from 2014 to 2018, and she is the newest member of the Lown Institute Board of Directors. So Mary, what do we know about how Black patients might be treated differently from white patients when they're in the hospital? We know, for example, that I think Vikas mentioned that they may be less likely to receive pain medication. What do we know about this kind of racism?
Thanks, Shannon. And you've done a really great job at showing the sweep of what we now are calling systemic or structural racism. And the key part of that concept that I hope viewers will grasp is that this is how racism works independent of individual racist ideas or personal prejudice. It's the way institution works. It's the way our culture has embraced the idea of white superiority and the inferiority of people of color. And of course, it affects our health system as well. So there are probably no studies that have outdone the Institute of Medicine's unequal treatment, which is now 15 years old. It focused principally on what happens to people once they walk in the door in terms of their medical care. And not only are there ideas that date really back to the period of enslavement, when the medical profession endorsed certain ideas that Blacks were less, sensitive to heat, had, more tolerance for pain, even ideas about the lung capacity that Blacks had compared to whites that endure in practice now. So recent studies have shown that not only do Black patients who are adults experience more pain before they get medicated. Children do. The unwillingness to prescribe effective pain medication extends to children. And this is one component of how structural racism works that means that people will worry about the quality of care that they receive, about the dignity with which that care is delivered, which you captured beautifully in the case of a celebrity who certainly has the ability to marshal resources for her care, and the ability of people to adhere to medical advice. But I hope we'll also turn to the fact that most of what determines how healthy we are occurs before we walk into the hospital. And more contemporary than all of this is the very disparate impact of COVID-19 that we're seeing. The analysis of, somebody should signal me when I should shut up because I can keep talking.
Keep going.
That's fine.
But we recently have published a paper. I and a couple of colleagues at the Harvard School of Public Health published a paper on that showed when you adjust for age, that Black Americans have 3.6 times the risk of dying of COVID-19 as compared to whites, and all groups have an excess risk who are people of color, including Asians, but the biggest gaps exist for people who are classified as African American, as Latinx, and Indigenous American Indian. Now, those are big differences. Huge. But if you look at it by age, keeping in mind that most people who die of COVID-19 are above the age of 65 today, there are much larger relative gaps in younger age groups. So among African Americans between the ages of 35 and 44, there's a 9-fold excess risk of dying of COVID-19. Now that includes everything. It includes the likelihood that you'll be exposed, the likelihood that you'll get infected, the likelihood that you'll get care, and what kind of condition your body is in at the time that you become infected, which may also be related to how you live and what kind of healthcare you've had access to. And all of those, exposure and susceptibility, have driven these absolutely unspeakable racial disparities, ethnic disparities in COVID-19, all of which really lay at the door of structural racism.
Can you talk a little bit about how,
Sure.
Oh, sorry, go ahead, Vikas.
I was just going to ask a question about that, because clearly huge factors in this preceded COVID.
Yes.
And so I'm really interested in how you would kind of describe what's happened in relationship to the buildup. Like, what are if you had to say, in terms of the public health, what are the biggest drivers or elements of structural racism in public health that led us to the situation we're in with COVID? And I want to add, your prior department just published in Lancet yesterday, I think.
Oh yeah?
That the actual mortality rates, or today actually, the actual mortality rates, infection fatality rates are really much higher than anybody has reported before. And so the numbers we're talking about are actually going to be much higher than we thought.
Yeah. I mean, there are two components of excess mortality, even greater than what I've described it, and these are reported deaths due to COVID-19. And they include people who were undiagnosed and people who died of other causes related to the disruptions of the pandemic. But you've asked, how would I parse it out? And I think about it as first the problems of exposure. And what's the likelihood that you're going to get exposed to this novel coronavirus? Now, my likelihood now is quite low. I'm sitting at home. I've been working at home since March. But when you look at who's still out there working, whose jobs were defined as essential. Many people think, oh, that's the doctors and nurses, and it includes them, and they have courageously continued to work at their posts, including, the doctors at besieged hospitals like Elmhurst, which we saw earlier. But the majority of people who are classified as essential workers are low-wage workers. People who are working in the warehouses, stocking the shelves, working the cash register, delivering our packages. These are jobs which are often precarious jobs. They don't carry benefits. They don't have paid sick leave. They don't have a living wage. So people are working multiple jobs. And then, of course, the housing crisis means that people live in crowded conditions. They may be piled up in multi-generational households where the advice that we give people, good advice for individuals, wash your hands, keep socially distant, it's just not practical to practice. So that's, those are two key things that I think about. The increasing vulnerability of workers as we've lost unions. There's the study that was done showing that unionized nursing homes were less likely to have COVID-19 deaths, for example. And of course, unions defend, wages and benefits like sick leave and health insurance. And then, of course, there's the housing crisis. Then there's the issue of how do you, what kind of condition are you in if you have, diabetes or heart disease or high blood pressure, things that we now call comorbid conditions. And that reflects the real crisis that we have in our healthcare delivery system and the quality of primary care, which is so terribly fragmented, which is often, not only often confronts the fact that not only do we have still millions of people who lack health insurance, we have many, many people who are underinsured, who are fearful of their co-pays. And to be honest with you, I don't know anybody who's sure that they're not going to get a bill when they go to the doctor, including me.
Isn't that the truth? Let's get Milton in on this now.
Okay.
So Milton R. Nuñez has over 30 years experience in healthcare, a strong background in IT and finance. He's had a track record of working with physicians, nurses, other administrators. He's at the Health and Hospitals Corporation, been there for over 20 years, and is currently the Chief Executive Officer of New York City Health and Hospitals Lincoln, which is in the Bronx. Just prior to that, he was the Deputy Executive Director in North Brooklyn at the North Brooklyn Health Network. So Milton, tell me about the community that your hospital takes care of. How do you see these issues of structural, kind of institutional aspects of racism playing out in the South Bronx where you're located? What have been the main challenges your communities face?
Right. So first, thank you for having me and for hosting this event. Dr. Bassett is a tough act to follow. She's incredibly knowledgeable. The South Bronx is a very vibrant community. A lot of energy. It's an immigrant community, Black and Hispanic majority community, but it's also a community that suffers through a lot of challenges. There you have on the screen kind of old Lincoln and new Lincoln. We actually started in Manhattan, and we opened our doors in 1842, home for the colored aged, and then moved to the Bronx in 1895. So we've had a rich history here in the Bronx. But our community suffers through many health and economic challenges. And those challenges really teed up the community in a way to get really walloped when it came to the COVID surge. Our Bronx Borough President every year publishes a survey done by the Robert Wood Johnson Foundation, and the survey ranks the 62 counties in New York State. The Bronx is ranked, it ranks it in health outcomes. The Bronx is ranked 62 out of 62, in other words, dead last. If the South Bronx were its own county, we'd probably be ranked 63rd. So poor health outcomes, really challenging health factors, quality of life is also an issue. And some of those health outcomes, which we've touched on, obesity, heart disease, asthma, substance abuse, mental health, are some of the things that we deal with every day. You superimpose homelessness on that, and the challenges that the community is facing are really tough. Now, how we see structural racism every day and how we're working to address it, first of all, we're lucky to be part of a public hospital system that's very responsive to the needs of the community and needs of the city. Is it enough? Probably not. The most obvious manifestation of structural racism, and we're trying to address this, is access to care. If you look at, and you had hinted at this on the map, if you look at access to primary care here in the Bronx, for every 2,000 residents, there's one primary care physician. If you go across the river in Manhattan, it's 730 residents per primary care physician. So right there, getting access to primary care services, big challenge. And the question is, well, why aren't there more primary care providers in the Bronx and in the South Bronx? If you look at dental services, and we know that good oral health is important for cardiovascular health. In the Bronx is one dentist, 2,000 residents. In Manhattan, it's one dentist, 570 residents. So you have this gap in access already baked in. And it's not for a lack of recruitment. We look to recruit primary care physicians, and we look to recruit dentists to address this in very practical ways. But there are still barriers to folks choosing to practice elsewhere rather than in this community. So number one issue that we work on and tackle every day is access to care, access to primary care, access to dental services, access to specialty care. And so if you can't get access to primary care, getting access to specialty services becomes even more daunting. Getting access to clinical trials for cancer care, for example, becomes even more daunting. There have been gains made on insurance coverage through the Affordable Care Act, through NYC Cares, but that still hasn't bridged the gap because we still have a shortage of providers, shortage of clinicians to be able to provide this care and bridge this gap.
Milton, so thank you for that. I want to dive in a little bit more with all of us now, and look at some of the ways in which we were able to measure, or at least create a measurement tool for an underlying pattern. And I want to walk you through that. And then, get into some of these questions. How do people choose which hospital they go to? What determines that? What do hospitals do, or could hospitals do to change that? And what other factors outside the hospital's control could we change as a matter of policy and politics that might change that? So let me just walk you through a tale of two hospitals. It's what we have decided is kind of a fundamental finding of our work with the inclusivity metric. So Lincoln Hospital ranks #1 in the country on our inclusivity metric. And a hospital 22 minutes away on subway, Lenox Hill, ranks far, far lower in the lower 5% in the country. And so we wanted to try to understand a little more what that pattern looks like. So as we drill down, this is what we found. On the map here, we're showing in purple the catchment area, the zip codes for Lincoln Hospital. Lincoln Hospital is the blue dot on the just off center upper to the right. Lenox Hill is the one lower down and on the left. The shaded zip codes in pale yellow are Lenox Hill's catchment area. Now, I want to remind everybody in the audience that the data we used was Medicare data. So that means a couple of things. These are older people, obviously. Well, not obviously, there are others on Medicare. But this shows that the reimbursement, that what the money flowed to hospitals was really the same or close to the same. And so that's not an immediate driver. What you see in purple is a pretty far-flung catchment area for Lincoln Hospital. I mean, it goes down to parts of Queens, Brooklyn, and further north up into the Bronx and in the Northeast. I'm not quite sure what that area is. The circles represent what we defined as the actual catchment area. The dark, thick purple circle is how we defined it. So we didn't include everybody. In their mathematical ways, we made that decision, which we can talk about, but it's written up on our website. And for Lenox Hill, what you see is a very far-flung catchment area, all the way up into the Hudson Valley, out to Long Island, the suburbs of New Jersey, perhaps all the way out to Connecticut. And so it's a much larger catchment area. And, again, we defined the Lenox Hill catchment area with that circle. So there are areas beyond that circle that we did not include. And then we did an analysis. And our theory was people can come from within those catchment areas. What's the pattern and what do the patients look like and what does that catchment area look like? And so for people of color in the catchment area of Lenox Hill, 57% of the people in that area, these are people over 65, are people of color. For Lincoln, it's 63. So Lincoln Hospital has a slightly greater proportion of people of color in their catchment area. But if you look at the people who actually that hospital serves, who come within the four walls of that hospital, for Lincoln, 32% are a substantially reduced fraction compared to the catchment area. And for Lenox Hill, and for Lincoln, a substantially greater fraction. So that's kind of, in a nutshell, what we see by race. And just to illustrate, issues of class, certainly in other parts of the country, that's important. In New York City, race and class are probably highly collinear and may in fact co-vary so much that it's hard to distinguish them. But here's the catchment area income for Lenox Hill and for Lincoln, almost identical. And now here's the actual patient population's income for each of those two hospitals. And so what we see is Lincoln is not only serving people of an income, on average of 52, but the people who come to the hospital have income almost half of that. So it's really a poorer section of their own catchment area. And for Lenox Hill, it's very much the other way. So these are the findings. As I said, we could reproduce that all over the country. But Milton, I don't want to put you on the spot exactly, but I want to ask you, how is it that this pattern has emerged? What kinds of things do hospitals do or could hospitals do that could alter this? What do you do? And in fact, what could other hospitals do? And to Mary, similarly, what kinds of active encouragement or discouragement do you think hospitals conduct to either be more inclusive of people of color or less inclusive? Why don't we start with you, Milton?
Sure. So thank you for that question. It's a great question. We really focus on serving our immediate community. We have 5 or 6 zip codes that constitute the a good chunk of our patient base, and our staff look like our patients. Many of our staff live in the neighborhood, which I think is a big plus for us. We also have a community advisory board that is very engaged and keeps us and holds us accountable to make sure that we are serving our community in value-added ways. We're never going to be the facility that is going to be advertising all over the city to attract patients from Westchester or from Queens or from Brooklyn. We are going to be focused on our immediate community. And when we do that, we're able to attract folks who live in our community, and we're able to hire folks who live in our community, and we're able to find folks that are willing to volunteer and serve on our community advisory board, which speaks to governance and speaks to how we're held accountable for serving our community. I think if more hospitals took that approach, the patient base that they serve would reflect the community that they serve.
So, Mary, let me ask you a little embellishment to the same question, but let me pose it as a criticism of our own metric, and that's this. Milton's described what I think is a very community-focused, community-oriented, and in some ways accountable hospital. Lenox Hill is serving a very different population. Sure. And if anything, in a, how shall I put this, in a racialized, class stratified society, where Lenox Hill is pulling people from all over, many suburbs, Connecticut, Long Island. How do you even define a community for a place like Lenox Hill? Are we being unfair? What could be different, and how might that be done?
Well, let me just be upfront, since this is supposed to be one of my big advantages of now being in the academy, that we have a fragmented healthcare delivery system that is divided between a public and private system. And the public system is generally has been shrinking greatly. In New York City, we are very lucky, or I still consider myself a New Yorker, that there is, that there's such a robust public hospital system. There are 11 public hospitals in New York City, and I'm a product of the training of one of them, Harlem Hospital, which is right across from your hospital, Milton. Yep. So the private system, although it's notionally nonprofit, is in fact driven by profit, and the fact that that people are going to these hospitals has very little to do with what community they feel they're from, as compared to what class they're from. And all of this would be addressed if we had a single payer health system and a national health insurance that meant that took all of this stuff out, all of your marketing, Milton, all of the variation in resources, because the public sector valiantly serves its community, but it's under-resourced. That would answer it. But I believe that every hospital should have a responsibility to the surrounding area. Somehow, the private hospitals in New York City managed to shift that responsibility to the public hospital system. And how they do it, I can't fully explain. Part of it is, who has public health insurance and the ways in which private hospitals avoid taking patients who have public health insurance, like the specialty hospitals, like Hospital for Special Surgery, or, the cancer hospital.
Memorial.
Yeah, like you look at the percent of their patients who are insured by Medicaid, it's like under 5%. So how are they doing this? I'm not sure, but it's a problem. And they shouldn't be permitted to shift their sicker, poorer, browner patients to the public system, but that's what they do.
Well, we know a little bit about how they do it. I mean, it's sort of interesting when you look at the,
yes, you're right.
when you look at the,
do it.
yeah. I mean, when you look at the photo of Lincoln versus Lenox Hill, I mean, Lenox Hill's entry looks like it's a co-op with a doorman.
Right.
And I would suspect that a lot of the patients that go to Lincoln usually are the doorman. They're not the person going in to visit somebody, or they're not the person living in this fancy building, and they're not the person who feels comfortable walking into that hospital. We also know that—
I was talking about more direct things.
Yes.
Like
they're the person who, the doorman or the environmental services worker, who before COVID were working, and now after COVID are not working, and we have a 21% unemployment rate in the community.
And they probably lost their insurance, or may have lost their insurance. So, we know the other reason of why is that private insurance pays better. And there are certain procedures that pay better. So one of the ways you can, as a hospital marketer, you can basically say, you can advertise in rich neighborhoods that you do this particular procedure that's a very high margin procedure that Lincoln might not be able to do, or might not think is that important to do, because you have other things that your patients need much more. And so the hospital, the private hospital that effectively is acting more like a for-profit business, needs to look for those patients who can pay and who have private insurance. And so I think that's part of what explains it is really overt marketing. But, it also raises the question of how much of this has to do with sort of self-selection of people of color. Are they going to Lincoln because they feel more comfortable there, or they're maybe they could go to Lenox Hill in terms of how far away it is, but are they choosing to go to a Lincoln, and why would they choose that?
That's a really interesting question, and probably Milton should mainly answer it, but let me just say a few things on that. One thing is that when you look at Black and Latino patients who are privately insured, they are also underrepresented at the at these private hospitals that seek a wealthy clientele. So that, there are two things that could help explain that. One is patient preference. And I was really glad that you, Milton, mentioned the fact, we're going to be talking a lot about the many burdens of bad policies that have affected the people of the Bronx. But we always have to also remember that these are vibrant communities, not only to themselves, but they're the source of culture that is embraced by the mainstream. And, we don't only want to tell this dreary story, but people actually feel safer when they go to a hospital where there are people who look like them, who live in their neighborhood, who they are confident will not experiment on them. As a medical student, I walked into a private hospital where I was on staff. There was a Black man draped, his back, exposed. One medical student was reading a book, and the other one was preparing to do a thoracentesis, put a needle in his chest, unsupervised. And I remember I said, what's going on here? And it was the patient who answered me. And he said, I think they don't know what they're doing. And I said, everybody stop. And, you know, I was a fourth-year medical student. These were third-year medical students. But just to give you the idea of the type of thing that goes on in a society where Black and brown bodies are undervalued and viewed as you know, as valuable mainly for their utility to others. So, so people feel safer. Certainly when I was at Harlem Hospital, our patients viewed us as doctors at a community hospital, that we were their hospital. The other possibility is that these hospitals like Lenox Hill or the other ones I've mentioned, you know, have somehow managed to ensure that that patients of color, even when they have insurance that they would otherwise accept, don't seek care there. I think that deserves some investigation, because that's you know, old-fashioned discrimination, and I, you know, I think we should answer it. But I'm going to turn it over to you, Milton, and just reiterate how all of New York should feel safer because it has a robust public hospital system.
Right. I mean, the public hospital system in this city is the best in the country, and you know, hands down. But you know, for me to go from the South Bronx to Lenox Hill, and Lenox Hill, incredibly clinically talented institution. But if I had public health insurance and I wanted to go to Lenox Hill, the first question is, well, do they accept my insurance? That's one. They may not accept my insurance. If I had commercial insurance, that may also be a question. But even if they did, right, there's the issue. I would frame it as comfort, right? Would I feel comfortable going to an institution where folks don't necessarily, where don't necessarily look like me, or the workforce may not look like me in large numbers? I think if you had large numbers of individuals, folks, residents from the South Bronx, hopping on the subway and presenting to Lenox Hill in large numbers, I think you would get an energy where folks may not be comfortable, and that's just the honest truth. And so there is a perception or a barrier there that keeps folks from getting off at that subway stop, and if they're going to leave the South Bronx for healthcare, they're likely to continue to stay on the train and go to Bellevue. They're not going to get off at 86th Street or 72nd Street. That's just the reality. And that's just one of the issues that we as a city have to get through.
So you know, and
let me ask you something, riffing off of something Mary said. Let's unpeel the single payer issue a little bit, because you mentioned to me in an earlier conversation that New York City, being New York City, the number of truly completely uninsured is very, very small. You're lucky that way. So people have insurance. But what's also true is that rates of compensation through hospitals vary tremendously.
Right.
So in a single
depending
payer,
on the insurance, right?
Exactly. And so in a single payer system, let's imagine a single payer system that paid, and this is of course a big policy discussion variously around the country and internationally, but let's say a single payer system paid Medicare rates. Do you have any sense of what that would do if all your patient population, if your hospital was getting Medicare rates? What would that do to your resources, and what might you be able to do in your community with that difference?
Right. So that's a great question. So Medicaid certainly doesn't cover our costs. We're extremely efficient, and our clinical staff is extremely productive, but Medicaid simply doesn't cover our costs. If we had Medicare reimbursement as kind of the base rate with capital reimbursement, we would certainly be able to expand the scope of services that we would provide. We would be able to offer more specialty services. We would be able to offer better access to primary care, more screenings. We would just be able to do more. We're obviously not in this to profit, but we would absolutely be able to offer more access. We could run our primary care practices longer. We could run them 7 full days a week. One of our biggest wait times is, for example, ophthalmology. Boy, with Medicare reimbursement, I could have ophthalmology access that would rival anyone in the city and anyone in the state and maybe even the country. So Medicare reimbursement would be a big winner if we can get that on all of our patients.
You know, here's the irony, Milton. A lot of private hospitals, CFOs will tell you that they lose money on Medicare rates. So I think there's a bit of variability in how efficiently hospitals run. Yep. And what they think of as decent compensation for their physicians and their executives. Right. And what they think are essential capital investments like equipment and things like that. And so
I don't need an atrium.
But there's a very interesting sort of counter argument to this idea that if everybody got the same rate for an individual service that they delivered, if all hospitals were paid the same by all payers, by all insurance companies. We have an experiment in Maryland. And in Maryland, they've had for 30 years the all-payer rate base where everybody gets the same amount, regardless of who the payer is. And yet, even in Maryland, there are efforts by hospitals to avoid Black patients in various ways, like not upgrading your emergency room so that which is one of the avenues through which many Black patients come. So, and there's a long history of racist experimentation around the country, and including Maryland, that I think may be a legacy of how Black patients feel about going to different hospitals as well. So you know, I guess what that says to me is that these are very complicated issues. It's multifactorial, and while changing by changing this differential between private insurance payment and Medicare and Medicaid would go partway towards changing the behavior of hospitals, I don't think that it will completely solve our problem of the structural racism in healthcare and in hospitals.
Yeah, you've put it really well, and I think that in medicine, those of us who are medically trained, we have to acknowledge that there's a deep belief that was embedded in our training that Blacks are biologically different. Mm-hmm. When I trained than whites, then I think that it may still be this way, but these something called a spirometer, which you used to test in the emergency room for people who came in with asthma attacks. There was literally a setting that you did for whites and for Blacks. And similarly, to this day, there are adjustments in, you mentioned some of them, also in kidney function, all based on these ideas that Blacks' biology is different, that the excess mortality rates and poorer health are related, are intrinsic in being Black. And you know, these ideas need to be addressed in the curriculum, in our society, but they feed this notion that these are patients we can't really look after. They're so sick, and it's because they have these, you know, problem bodies, and we can do our best for them, but they'll never be as healthy. And this is pure and simple racism. But it persists, and that is, you know, our challenge. We see it, you know, in everything, in police violence and so on. But the fact is, Reverend Barber, who leads the Poor People's Campaign, says racism had a beginning, and it will also have an end. So I actually believe that, but I agree with you that there's no magic bullet.
From your mouth to God's ear.
Yeah.
Jewish
So,
saying goes.
but we're running out of time, but
Yeah.
I see a couple of questions. Maybe we can
Yes.
grab a minute or two. So a question for you, Milton. What percentage of the non-physician or non-professional staff at Lincoln have union representation?
What percentage of the non-physician staff?
Yeah.
It's got to be 90%. And our physicians are also represented by our Doctors Council Union. So even our medical staff is 95% unionized.
Wow.
Actually, our non-physician staff is probably closer to 96%, 97% unionized.
Got it.
So,
Go ahead.
so I think let's move on to the question of what the solutions are. Are hospitals stuck in this dysfunctional and racist system, or are there actions that hospitals can take, and in fact, maybe even individuals in hospitals can take to become more inclusive and to advance health equity? So, so Milton, you've already kind of described some of what Lincoln does so well to be inclusive. But one question is, to what degree can other institutions use what you're doing as a model? And I'd love Mary to jump into that as well.
Sure. So again, to reiterate, I think the accountability to the community, to the immediate community where the hospital is physically located, I think is really important. Having community representation on the governing body is extremely important. I think governance is extremely important. If you do not have community representation, and we have two boards. We have our community advisory board, and they're advisory. They don't have any legal power, if you will, but they're extremely important. And then we have our governing body, and those two bodies have community representation, and they're very much connected to our elected officials, who are extremely supportive of the hospitals across the system. So that community accountability and community representation is extremely important. The other thing that hospitals can do within the walls of the institution is really talk about and practice and recognize and work on implicit bias, unconscious bias. That really needs to be part of the conversation that takes place within the four walls. We started that journey here. We started that journey across the public hospital system. But this is, if you're going to solve an issue, you got to actually be honest about it and upfront about it and put it on the table and say, okay, how do we work this problem? And so be willing to have really hard, difficult, honest conversations is really important.
Mm-hmm. Mary, do you have any thoughts about what other hospitals can do, what they can adopt from Lincoln that would be, say, the most important in your mind?
I think Milton has outlined it really beautifully. Additionally, of course, Lincoln Hospital has a long history of solidarity with its community. When I was a medical student, I made the journey to Lincoln Hospital to have a meeting with Helen Rodriguez-Trias, who I'm sure you've heard of her, even though she was way before your time. She was, a community advocate, a leader, a public health leader, and she also led in ending sterilization abuses. It used to be that women would be approached to be sterilized while in labor. And she, this happened disproportionately to Latina women and Black women. So this history of solidarity is something that I think has also helped. I don't know how that can be done using other hospitals, can use that as an example, except to acknowledge the ways in which they have failed to have solidarity with their communities and begin to go out and seek to relate to their catchment area. What the hospital index does for me is point out that hospitals play more of a role in a community than simply delivering care. although of course that's what all of us expect from them. But their employers, their real estate, you know, they're more than simply a healthcare system, and they have to look at all of their roles. Lincoln does that, and other hospitals can learn from it.
Let me jump in and ask a kind of related question, which is, you know, we clearly aren't training enough clinicians from minority communities. We're not training enough from rural communities as well, as a matter of fact. But in terms of training of clinicians, what could we do to increase that? And then a kind of secondary question for you, Milton, but Mary may have a view as well. From a policy point of view, what could large institutions do to make that more likely, more possible? And then a third related question is, when you have primarily white physicians coming to Lincoln, do you just depend on the sort of natural selection process of who's coming? Or is there some way in which leadership at the hospital can play a role to kind of, whether it's on the implicit bias front or whether it's on selection, various kinds of ways of making the issue of racism at the top of the agenda and something that is active conversation in the hallways?
Right. So let me tackle the second part, the second question. I think one of the programs that the public hospital system has started with the city is a scholarship. We've partnered with foreign medical schools, right, to provide them with places to train their medical students, right? That has created, and this isn't just an example, that has created an opportunity, and these are well-regarded medical schools generating very well-equipped, well-trained students. We now have a scholarship program set up with the city and H&H for medical students from some of these schools, that if they go into primary care and they go into these difficult to find specialties, that we will then hire them and we will pay for their schooling and then hire them here in the public hospital system. So that's one example of not simply depending on the US-based medical schools, but also foreign medical schools to be able to provide us with a pipeline, if you will, of folks that will train here and work here. The other part of your question on are most of the clinicians here white? Certainly, the clinical leadership is quite diverse, and our residency programs are actually quite diverse. Whether it's in medicine, emergency medicine, or surgery, our residency programs are quite diverse, and that will give us a pipeline to recruit and retain, once they finish their training, physicians who will work here at Lincoln. So those are two things that I wanted to mention. A program that is available that we think will increase the pipeline. Repeat your first question for me again.
I'm not sure I can remember.
I can come in and just say something on activities outside of the walls of hospitals. It's really been social movements that have driven the biggest shifts in these issues that we're talking about. I'm a product of those movements. I went to medical school in the 1970s. We're now down to numbers of Black students, particularly Black men are critically underrepresented in medical school now, that we're down to the numbers that are about the same as when I went to medical school. So it's an act of will on the part of the medical schools to increase their enrollment. And I haven't seen an attention to the enduring impact of racism in US society on the level that we've seen over the past months and 50 years, and so I'm very hopeful that these, in spite of the pandemic, which itself is showing us the enduring impact of systemic racism, I'm hopeful that the attention won't shift and that it will be addressed in multiple sectors, including medical education. There was something in the chat about should we have work on racism in medical school, or should it be focused on implicit bias? And the answer is yes, but I don't think that once is enough. And I really applaud the public hospital system for embracing this for its staff. We did this at the health department when I was there. I do think that implicit bias shouldn't let us get rid of the fact that there's still explicit bias. Shannon has talked about some of that. And so it's not all unconscious. There's still a lot of quite conscious racism, but that these reflexes that are so embedded in our society, have to be tackled, and that's the strategy to do it. And maybe now somebody has remembered the last question for Milton.
Well, but to either of you, or I think we all four can chime in on this. What can individuals who work in hospitals do? I mean, I'd like to see a bunch of people wearing white coats out with the demonstrations on the streets, and I'd like to see demonstrations in front of hospitals talking about these issues for sure. But what can individuals inside of hospitals do to really combat this racist problem?
I think let me comment on the folks in white coats and in demonstrations. One of our proudest moments was when George Floyd was killed. One of our proudest moments was how our residents and our medical staff rallied with the community and demonstrated with the community, and were seen with the community to talk about justice and equity. They actually, in many ways, led the charge. Administrators were kind of busy getting things done and trying to run the hospital, but our clinical staff in many ways led the charge so that the Lincoln voice was heard loud and clear in this neighborhood. And they made common ground with our community advisory board and with the community and demonstrated with them. So we were very proud of them when they stood up and were counted in such a visible fashion. And then again, what folks can do within the four walls of the hospital is be willing to talk about these issues and put these issues on the table, that the intoxicated patient that has arrived is a human being. They do have a family, they have a history, they have a future, and that working together to deliver excellent care to that intoxicated individual puts us all in a better place. But it's a willingness to talk about these issues and put them on the table that I think is the best way to deal with this.
Well, can I suggest that the Black Lives Matter movement has made what Mary did when she was a fourth-year medical student a little bit easier to do, which is to speak up and to point things out and say, this is not okay.
Absolutely.
That was courageous back then, Mary, and maybe it takes a little less courage now, but it still has to be done over and over and over again, doesn't it?
Yeah.
Yep.
Yeah.
So other questions we have. I think we've already talked about improving the diversity of physicians and executives in hospitals, but I think there are policy answers to that question. It's not just up to the individual hospital. I think it is also an issue that policy can address, especially organizations, medical organizations like the the AAMC, the American Association of Medical Colleges, or am I saying that right? I'm not sure.
Yeah.
The AMA, all of the specialty societies should be saying something about the need for greater diversity, and then to set standards for medical schools and for residency programs to say, and for nursing programs to say, you gotta start recruiting. And I've always thought that one of the problems that we have right now is it's extremely expensive to go to medical school, and it's also getting increasingly expensive to go to nursing school. And what that does is it shuts out a lot of people from poorer neighborhoods who might well turn out to be fantastic clinicians and would return to their neighborhoods to serve their communities if they had the opportunity to get into medical school, to get into nursing school, to get into medical technician programs. So I think there are many things that policy can do to actually improve that situation, that piece of the problem.
Let me ask, let me try to stir up things a little bit in another dimension, which is, speaking of policy and speaking of regulatory action, we talked a little bit about, how a single payer system might help an institution like Lincoln. But right now, what kinds of policy or regulatory changes could we imagine that might improve the situation? So for example, nonprofit tax-exempt hospitals are supposed to show and actually spend money on community benefits that involve a range of different activities in order to justify their nonprofit status. And of course, in the Lown Index, we've looked at that nationwide. But, I was just musing the other day, what if there were categories for community benefit spending that specifically required addressing some of the issues of racial disparities? What if that were not just a good idea, but the law? What if there were ways in which how hospitals advertise or how they plan their capital budgets and how much they put into primary care, or what neighborhoods they provide? What if that were under greater scrutiny? Essentially what I'm saying is, we have this sort of sharp division, as Mary pointed out, between public systems and private nonprofit systems. What if we really drove them closer together in a regulatory framework that really required everybody to play on a level playing field? Does any of that make sense?
It does, but it would require, a type of leadership that is difficult, because the hospital sector is very powerful in a city like New York. It's finance, it's healthcare delivery, and it's real estate. These are the sort of powerful actors in the New York City economy. I think it's a reasonable question to ask about nonprofit status of hospitals that are converting their real estate assets into, decommissioning their hospitals and turning them into condos. Ask the question about what community benefits mean. I personally, I understand health fairs as a marketing tool, but I don't really understand them as a community benefit. And I can just give you a couple of anecdotes from when I was commissioner. We had a greatly reduced advertising budget for, and when Tom Frieden was commissioner, he spent $10 million a year in the New York City media markets to buy television time on tobacco, anti-tobacco messages. And we simply didn't have the money to do that anymore. But I thought, this benefits everybody, because we can see a benefit of reducing tobacco use very rapidly. It's not like you have to wait 20 years. There are really impacts on the risk of coronary artery disease, fatal coronary artery disease. So how about I go to the hospitals and see if we can pool our money and all have a public campaign? Well, boy, was I naive to think, that we could get that kind of. Now, I'm not talking about the public system, which in my view appropriately operates in red ink, because this is something that without, for which there should be a investment of taxpayer dollars to ensure. I don't even think we should consider it red ink. I think we should consider it like having a fire department. But I just wasn't, I wasn't able to do that. And it would be really great to see some kind of obligation to population health metrics of all, of the whole hospital system.
I think Senator Grassley, a few years ago, attempted to hold or shed some light on this non-profit, not-for-profit status, and exactly how much charity care and was it meaningful charity care that was being provided. So the question's been asked in the past. I don't think anything ever came of it. But specifically on the issue of real estate, and it's not just a New York City issue. New Jersey, for example, has the same issue. You have healthcare systems that own fairly robust real estate portfolios and pay no taxes on those portfolios. It's not just hospitals. Universities are also in this mix. But if there's one area that is kind of easy to understand and easy to quantify, is how much real estate do some of these healthcare networks own, and is it a good idea for them not to pay any taxes to the community that they're in?
Yeah.
And some of these are not directly relevant to delivering health services. Is that right? Yeah.
Right.
Oh,
So it's
yeah.
hard to understand the rationale, for tax-free status for.
Yeah.
No, they have significant
remember,
portfolios.
I remember talking to an acquaintance of mine who ran a for-profit network of hospitals that was backed by private equity. And at some point, one of his associates said to me, well, you realize this is really just a real estate play. And I was like, naively, I was like shocked, but now I get it.
Yeah. And there's another interesting question from the audience which is, do we at the Lown Institute have a plan to look at race and gender in our pay equity metric, which looks at the differential between the CEO's pay and the average pay of non-clinical workers at the hospital, like people who work in the kitchen and people who are in janitorial and doing the CT tech and things like that. I wish we could. There's not, as far as I know, no national database to be able to get at those things. Likewise, it's difficult to get at whether or not hospitals are paying a living wage to the lowest paid workers, which is a really important question. And something we didn't really touch on too much here is about how the community conditions, the sort of availability of good food, the safety of sidewalks, how clean the air is, whether or not there's a good school for kids, how those community conditions have this tremendous impact on health, not just individual behavior. And so, there are many things we can't quite yet measure, but I think are really important to start holding hospitals accountable for, including that living wage, because they are often the largest employer in a given community, and your wage has a lot to do with your health.
Right.
I have to apologize. I've just been buzzed that I'm supposed to be on another call now. I don't know how that happened. Hang on one sec.
Milton, go ahead. What were you going to say?
One way to create an incentive for hospitals to opt in to voluntarily report some of these metrics that you're reporting, that you're referring to. So one example would be the Leapfrog survey. Leapfrog, and when it first came out, everybody was kicking and screaming. right? Nobody wanted to do it. And they may still kick and scream, but for the most part, hospitals have opted in to this voluntary reporting of quality metrics, right, and some outcomes, because the alternative of not reporting then raises questions. Well, you know, why is it that you're not looking to participate? And yeah, the methodology may not be perfect. No methodology is ever going to be perfect. But you know, folks went kicking and screaming, but so many of them now participate in the Leapfrog survey that may be one way to get folks to participate in pay equity, in you know, difference between the CEO and the lowest paid employee, living wage, to go along with their Leapfrog survey, to go along with their Joint Commission certifications and all that good stuff, all that great stuff that people do. But I think an opt-in, peer pressure is a great way to get folks to move.
Mhm. Mhm.
Yeah, agree completely, Milton. We're hoping that our own index will have enough prominence over the coming years that we'll have the clout to actually do that, because I think that's right.
May I, and I apologize for spacing out for a second, but have you made public any of the ratios of lowest to highest wage from your?
Yes. Yes, the ratio is what we rank. We've reported the ranks, but not the ratios.
Can you just give me? I'm curious what
Yeah.
what
So let me.
what
So
kind of range you saw.
yeah.
Let's be mindful. It's 225, so let's be mindful.
Okay.
of our
So
Well,
I'll just very briefly and quickly. It depends on your perspective, right? If you compare it to Silicon Valley, geez, healthcare, they're freaking socialists, right? Because the highest, if I remember right, is about 18 or 20 to
20.
the average worker.
Yeah.
And I think that was Innova Health System in Virginia. So the large health systems, you know, the health system CEO generally makes beaucoup bucks. But some of them were
Just
very
20-fold more. I find that's hard to
Yeah.
believe, actually.
Yeah. In which direction? Too high or too low?
I thought it would be higher than that.
Yeah.
Yeah.
So
Maybe they outsource. Maybe all of their really low wage workers are all contracted.
well, that's the other
That could be.
dimension that we couldn't capture, which
Yeah.
is how much labor is outsourced. And somebody from SEIU contacted us and pointed that out, and we're aware of it. But some of the lower ones, especially smaller hospitals, part-time CEOs, you know, those were very, very low. They were often 1.5 to 1 or something like that.
Well, and safety nets obviously were
And
much
safety
lower
nets.
ratios.
And New York City hospitals, right? We're also in public and county hospitals tend to be much more modest in that way.
I know when I joined the health department, I had this idea. I'm going to say that we shouldn't have more than a 1-to-10 ratio across, and it was already less than that.
Yeah.
That's great.
Yeah.
That's great. Well, Vikas, do you want to wrap up?
Yeah, I think we should. I mean, I hope we've covered as many of the questions as we could. I just want to thank everybody for sticking with this and staying with us. I want to encourage the audience members to keep sending us questions and comments. And if you want to stay in touch as we do more Lown Presents, remember you can subscribe at lowninstitute.org/subscribe. And then lastly, I think, you know, our heartfelt thanks both to Milton and to Mary.
Yes.
Time is incredibly precious for all of us these days. And for you to give us this much time is very generous, and we really appreciate it.
Thank you.
Thank you so much.
Very
Thanks
good
to
see
everybody
you.
who attended and for all the great questions.
Yeah.
All right.
Thank you all. Take care.
Thank you.
Bye-bye.